Hello, this is Peter Durman, spine surgeon at the Texas Back Institute. Here I will be presenting a summary of the risks and benefits of lumbar disc replacement. This slide provides some context for our discussion. Despite its current lack of widespread adoption, the concept of lumbar disc replacement is nothing new. The first experiments with it began in the 1960s, and the modern generation of implants were developed starting in the 1980s. The goal of disc replacement is to address discogenic pain while maintaining motion so as to minimize the incidence of adjacent segment disease, especially as compared to fusion. There is strong data to support lumbar disc replacement in appropriately selected patients, and I will review some of these studies shortly. And while I hope to demonstrate that it is a relatively safe procedure, unique complications do exist and will be reviewed as well. Some of the benefits of lumbar disc replacement are as follows. It is a muscle-sparing approach, which is relatively minimally invasive. It is not dependent on fusion, so pseudoarthrosis is not an issue. There are numerous high-quality studies that have demonstrated clinical outcomes that are equivalent or superior to fusion. And there is also data that demonstrates that motion preservation results in diminished radiographic adjacent segment degeneration, as well as clinical adjacent segment disease. Finally, it is a cost-effective procedure compared to fusion, as supported by multiple studies using a variety of methodologies. At this point, I want to share with you some key studies from the arthroplasty literature. The first commercially available disc replacement in the United States was the Charité. It was cleared by the FDA after publication of 2-year data from a multi-center randomized controlled trial comparing it to anterior lumbar interbody fusion. For the primary composite endpoint, there was a significantly higher rate of overall success in lumbar disc replacement than in the fusion group. Additionally, flexion extension range of motion was restored and maintained in the lumbar disc arthroplasty cohort. Similar findings were reported at 5 years. The Charité was not inferior with respect to any endpoint, and in fact, produced higher rates of employment and lower rates of disability. 2 years later, in 2007, Level 1 data from the IDE study for the ProDisc device were published. At 2-year follow-up, authors demonstrated that lumbar disc replacement was superior to circumferential fusion in multiple study endpoints, including ODI improvement, overall neurologic success, and the composite for overall success. Furthermore, range of motion was maintained within the normal functional range in over 93% of patients in the arthroplasty cohort. At the 5-year time point, more patients in the disc replacement group than in the fusion cohort indicated that they would undergo surgery again. And segmental range of motion was maintained within the normal range in the arthroplasty group. One commonly voiced criticism of lumbar disc replacement is that operative intervention for back pain is inherently flawed. If fusion itself has historically produced lackluster outcomes in this setting, it may be a poor control group against which to compare disc replacement. Perhaps these patients should not have any surgery at all. In this multi-center RCT, patients were randomized to lumbar disc arthroplasty versus multidisciplinary non-operative care. At 8-year follow-up, LDR produced superior outcomes with respect to ODI, VAS, EQ5D, and the Hopkins Symptom Checklist 25. Significantly more patients in the lumbar disc replacement group reported a full recovery than with non-operative care. The most recent entry to the U.S. arthroplasty landscape is the Activale disc. The Activale IDE study compared the performance of this device to that of the ProDisc and Charité discs. At 2-year follow-up, the Activale was superior in terms of radiographic success and the primary composite endpoint, which was defined as ODI improvement of at least 15 points, maintenance or improvement in index level range of motion, no neurologic deterioration, no reoperation, and no serious device-related complications. There were no other significant differences between the groups. At 5 years, the Activale produced significantly better range of motion compared with the other discs. Significantly fewer patients in the Activale than the ProDisc Charité group experienced serious adverse events. As mentioned earlier, one of the primary goals of arthroplasty is to preserve motion, as segmental mobility is thought to be protective against degeneration at adjacent levels. There is now some concrete data to support this assertion. In this analysis of patients from the ProDisc IDE cohort, authors evaluated pre- and postoperative imaging to assess the development and progression of radiographic adjacent level degeneration. They found that this was greater than 3 times higher in the fusion than the disc replacement cohorts. However, differences in secondary adjacent level surgery did not meet statistical significance. This is likely due to insufficient statistical power to identify a significant difference given the small number of patients undergoing additional operations at this time point. In this analysis of 5-year data from the ActiveL IDE study, authors observed that patients undergoing disc arthroplasty had 1/3 the odds of experiencing progression of radiographic adjacent segment degeneration compared to a historical fusion cohort. Furthermore, there was a dose-response type relationship in which greater degrees of motion resulted in less progression of adjacent segment deterioration, which is pretty compelling data. Finally, this systematic review of the literature identified 27 relevant studies comprising 1,732 fusion and 758 arthroplasty patients. Authors report that, compared to arthroplasty, the odds of fusion patients developing radiographic adjacent segment degeneration was over 2.5 times higher, and the odds of developing clinical adjacent segment disease was over 17 times higher. Taken together, the literature for lumbar disc replacement is quite robust, containing multiple level 1 randomized controlled trials supporting its use. However, like any procedure, lumbar disc replacement carries risks, some of which are unique to this operation. Optimal outcomes for disc replacement require sufficiently robust bone to support the device and prevent subsidence. Bone density should be tested preoperatively on all patients being considered for lumbar disc replacement. Individuals with osteoporosis or osteopenia are not candidates for arthroplasty due to concerns for implant subsidence. If patients are close to but below the cutoff for normal bone density, a course of treatment with teriparatide to bring the T-score to within the normal range can be considered. Approach-related complications such as injury to structures, including the great vessels and ureters, is well documented. The approach itself is identical to that of ALIF, although wide and symmetric exposure is necessary. This can sometimes represent more of a challenge at L4-5 and other more cephalad levels than it does at L5-S1. Regardless, the approach should be performed by someone well-versed in the procedure and capable of identifying and managing complications. Careful attention must be paid to device position in the coronal plane, as eccentrically placed arthroplasty devices have been shown to result in asymmetric loading of the facet joints, with subsequent facet arthropathy and inferior outcomes. While uncommon, implant migration and polyethylene dislodgement have been reported. Appropriate sizing and selection of an implant with a keeled design when the anatomy dictates should mitigate issues with implant migration. Osteolysis from polyethylene wear, a well-documented late complication in the orthopedic total joint literature, has been observed only rarely with lumbar disc replacement. This may be related to the more limited range of motion present in lumbar disc replacement compared to total joint arthroplasty devices, as well as the non-synovial intervertebral environment. Heterotopic ossification, observed frequently in cervical disc arthroplasty, appears to be less of an issue in the lumbar spine, and HO prophylaxis is not routinely given in our group. Vertebral body splitting fractures are possible with the insertion of keeled implants. This is more of a concern in multi-level disc replacement, as cases in single-level disc replacement are rare. When it occurs, it is generally a radiographic observation without clinical significance. Despite all of these potential issues, a series of over 1,700 consecutive cases from our institution demonstrates that only about 1% of implants require removal or revision. However, a repeat anterior exposure can be daunting. Depending on the experience level of the surgeon performing the approach, addressing lumbar disc replacement complications after the early postoperative period is often best accomplished via conversion to fusion utilizing either a lateral or posterior approach, given the hazards of revision anterior approaches to the lumbar spine. Repeat access to L5-S1 may be facilitated by approaching via the contralateral retroperitoneum, but this is less feasible at more cranial levels. In conclusion, lumbar disc arthroplasty is supported by more level 1 evidence than almost any other spinal procedure. In carefully selected patients with symptomatic lumbar disc degeneration refractory to conservative care, it is a safe, clinically efficacious, and cost-effective treatment. Thank you.